training.
Yeah, yeah.
And I just want to tell everybody who is present here that you should go over the listen to everything, and at the end of the meeting they will just don't exit from the meeting. You stay for some time, and then you will get a continue button. You press on the continue button, and then you will get the post test and the feedback. You have to fill in and submit, and then you can get the certificate. So now, Kavita, you can start.
Is this for faculties also?
Yeah, we can also do, but mainly it's for the trainees.
Yeah, that I know, but we have to do.
Yeah, we can also. Yeah, we can also.
You can resubmit the form again.
Yeah. We can resubmit. Yeah, yes.
Yeah.
Okay, thank you, Rekha Madam, for the information. Respected seniors, colleagues, and the participants from different states and from different cities. Namaste and welcome to Respectful Abortion Care Joint FOXY and WHO Initiative Master Trainers Orientation Virtual Program 2022. Share just in a historic movement, amendment in MTP Act 1971 was made on 16th March 2021 to empower women by providing comprehensive abortion care to all. Start sharing. एक मिनट मैडम शेयर तो नहीं हो रहा, यहाँ से करो, यहाँ से करो. The amendments will increase the ambit and access of women to safe abortion services and will ensure dignity, autonomy, confidentiality, and justice for women who needed to terminate a pregnancy. Why not? I can share. अभी तो हो रहा था. फिर से एक बार करो. एक बार करो. Yeah, this one. उसको बड़ा करो. Yeah. Bas. So now can you see? Can everyone see?
Yes.
So today objectives of module 1, evidence dissemination. We will take a closer look at what are the new laws and what are the changes in the rules. Unsafe abortions in India lead to high mortality, morbidity, and hamper women and girls' full participation in standardized goal and sustainable goal development. About 8% of maternal deaths per year are due to abortions in India, and therefore is the third leading cause of maternal mortality. Nearly 2 out of 3 of the abortions performed are deemed unsafe, and nearly half of the pregnancy-related deaths are in women and girls under 24 years. So according to WHO, abortion is considered safe when it is done by appropriate methods and by trained personnel, that is mostly gynecologists. If both of these criteria are met, then it is called safe abortion. But if one of 2 criteria is met, then it is called less safe. And if either of the 2 criteria is not present, then it is called unsafe abortion. This Medical Termination of Pregnancy Amendment Act was brought on 16 March 2021, and its basic purpose is safe and comprehensive care mandated by law. These are the changes. Previous act was 1 medical practitioner was required for the termination of pregnancy up to 12 weeks. But now opinion of 1 registered medical practitioner for termination of pregnancy has been extended to 20 weeks of gestation. Earlier it was 12 weeks and now after amendment, it has been extended up to 20 weeks of gestation. Earlier, opinion of 2 registered medical practitioners was required for 12 to 20 weeks, but now opinion of 2 registered medical practitioners for termination of pregnancy required from 20 to 24 weeks of gestation. Its potential outcome is increase in number of facilities, especially in public sector, like primary health care, eligible for service provision till 20 weeks of pregnancy. Another modification for vulnerable group of women was made. Earlier, MTP was permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. But after amendment, this upper gestation limit has been extended from 20 to 24 weeks for special or vulnerable categories of women. Further enhancement has been made for birth defects not compatible with life on medical board consensus. Its potential outcome is increased access for vulnerable women to safe and legal abortion services defined by the rules. The committee includes violence victims, manners, among others. Modification for birth defect and congenital anomalies has also been done. The Act had provision earlier. The Act had provision for termination of such pregnancy only up to 20 weeks. But now, upper gestation limit does not apply in cases of pregnancy with substantial fetal abnormalities diagnosed by a medical board. Its potential outcome is increase in access to safe and legal abortion services, who often seek service late beyond legal limit for termination of pregnancy with substantial fetal anomalies diagnosed late, thus reducing unsafe abortions and thereby court cases. Modification has also been made in relation to marital status. Earlier, the condition of failure of contraceptive was applicable for only married women or her husband. But now, the amendment has been made, condition of failure of contraceptive for any woman or for any partner. Means it is now available for unmarried girls, widows, or divorcees. Its potential outcome is increased access to safe and legal abortion for any woman, irrespective of marriage age, especially with upcoming changes in legal age of marriage, an important advancement for increasing access to safe abortion. There was insertion of new clause for strengthening privacy. Earlier, the Medical Termination of Pregnancy Regulation 2003 mentioned that information should not be disclosed except under the authority of the law. But now, name and other particulars of a woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. So, its advantage is increase in privacy and confidentiality of the abortion seekers, increased demand, but need to be safeguard rights and dignity of the woman, and provide respectful bias-free services, including counseling as well as contraception. So these amendments made in 2001 prioritize confidentiality and safety. So name and other particulars of any woman seeking abortion to be confidential except to a person authorized in any law for the time being in force. And if it is not done, then there can be fine like imprisonment for 1 year or monetary fine. Another amendment that was done beyond a failure of contraceptive that has been extended to women and her partner, not only her husband. So these are the rules under MTP Amendment 2021. It defines special or vulnerable category for women eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks. The norms for registered medical practitioner whose opinion is required for termination of pregnancy at different gestational age that we will discuss, and powers and function of the medical boards, which comprises obstetrician or gynecologist, pediatrician, plus radiologist or sonologist, which are available. And that is formed for each state and mandated to provide timely evidence-based decisions. So special category women eligible for MTP between 20 to 24 weeks are these groups. First, survivor of sexual assault like rape, incest, women with pregnancy in humanitarian settings like disaster and or an emergency situation as declared by the government, change of marital status during the ongoing pregnancy like widowhood and divorcee, women with physical disabilities, major disability as per criteria under Disability Act, mentally ill women including mental retardation, minors, and the fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities that will be seriously handicapped. Norms for registered medical practitioner has also been amended, and RMP defined in the all date MBBS or more with any medical practitioner assisted in 25 cases of MTP, of which at least 5 has been done independently in a hospital by that person, that doctor, medical practitioner who has completed 6 months of house urgency in obstetrics and gynecology, medical practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. That means only gynecologists who have PG, either MD or a diploma, that they can do. And medical practitioner who has experience of at least 1 year in the practice of obstetrics and gynecology. And up to 20 weeks of gestation, opinion of only 1 registered medical practitioner required, and between 20 to 24 weeks of gestation, opinion of 2 registered medical practitioners are required, and beyond 24 weeks, opinion of medical board is necessary. These are the norms for registered medical practitioner. Under the amended rules 2021, an additional category provider has been added for termination up to 9 weeks with medical methods. Earlier, medical method was not available, but now it's easily available. So, medical method of abortion can be used up to 9 weeks of gestation. For that, registered medical practitioner should have experience in the practice of obstetrics and gynecology at any hospital for 3 months, or they should have training with performance of 10 cases of MTP by medical methods of abortion under supervision of a registered medical practitioner in a hospital established or maintained or a training institute approved for this purpose by the government. Again, opinion of one registered medical practitioner required for 20 weeks of gestation, and between 20 to 24 weeks of gestation, opinion of 2 registered medical practitioners is needed, and beyond that, medical board's opinion is necessary. The norms for the RMP, whose opinion is required for termination of pregnancy, varies according to gestational age. Till 9 weeks, experience and training required for registered medical practitioner are experience at any hospital for 3 months in the practice of obstetrics and gynecology, or has independently performed 10 cases of MTP by medical methods under supervision of registered medical practitioner in a hospital that has been mentioned. Another is a practitioner who has assisted a registered medical practitioner in the performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. Third, a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. Fourth is a practitioner who has completed 6 months of housemanship in the obstetrics and gynecology. And fifth is a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. And for 9 weeks of gestation, opinion of one registered medical practitioner is required. Till 12 weeks, experience and training requirement for RMP. First is a practitioner who has assisted a registered medical practitioner in the performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. Another one is second group, a practitioner who holds a postgraduate degree or diploma in the obstetrics and gynecology. Third is a practitioner who has completed 6 months of house surgeonship in obstetrics and gynecology. Fourth is a practitioner who has experience at any hospital for a period not less than 1 year in the practice of obstetrics and gynecology. Difference between medical methods and surgical methods is here in medical methods only assistant for 10 cases were required, but here it has been extended to 25 cases. And again, opinion of one registered medical practitioner is necessary. Beyond 12 weeks till 20 weeks, experience and training requirement for RMP are: first, a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. Second, a practitioner who has completed 6 months of house surgeonship in obstetrics and gynecology. Third is a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. And again, opinion of one registered medical practitioner is required for up to termination of pregnancy for 20 weeks. Beyond 20 weeks till 24 weeks. Here, experience and training requirement for registered medical practitioner varies. First, a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. A practitioner who has completed 6 months of house surgeonship in obstetrics and gynecology. A practitioner who has experience at any hospital for a period not less than 1 year in the practices of obstetrics and gynecology. An opinion of 2 registered medical practitioner is necessary. But sometimes, if patient is very serious, to save the life, even opinion of one registered medical practitioner can be taken to terminate the pregnancy, even up to 24 weeks of gestation. But mostly, opinion of 2 doctors is required. Beyond 24 weeks, here experience and training requirement is a bit different. A practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. A practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. And thereafter, opinion of medical board is required. for the termination procedure when advised by the medical board is carried out with all safety precautions along with the appropriate methods and at appropriate place. So medical board comprises a gynecologist, a pediatrician, and a radiologist or sonologist. This board should be formed at the state level. Powers of medical boards are to allow or deny termination of pregnancy beyond 24 weeks of gestation period only after due consideration and ensuring that the procedure would be safe for the woman at that gestational age and whether the fetal malformation has substantial risk of it being incompatible with life or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. If the board thinks that if the child born will has serious handicaps and it will not allow her, the baby to survive, then they can allow for termination. And they can also co-opt other specialists in the board and ask for any additional investigations if required for deciding on the termination of pregnancy. FOXI, with ministry guidance and WHO support, is part of respectful abortion care, can operationalize and host medical board information on website. Another function of medical boards are to examine the woman and her reports who would approach for medical termination of pregnancy, provide the opinion of medical board in Form D with regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving the request for medical termination of pregnancy, and to ensure that the termination procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of the request for medical termination of pregnancy. So FOXI has an important role to play in ensuring there are functional medical boards in every state as is stated in MTP Amendment 2021. So this is registration. We have, most of us have done pre-test, and now after the completion of this session, all the sessions, there you have to continue and you will have to appear for post-test, then only certificate will be awarded to the participants on attending the training and submission of the registration, pre-test, post-test, as well as feedback. So in India, abortion is legal. Let us make it safe and respectful. Samarth Bharat, Sampurna Bharat. Thank you. Thank you for patient hearing. So now I should stop sharing. Hello. Thank you. And now I request for module 2. Dr. Pratibha Singh. Pratibha, you will speak?
Yeah.
So start sharing.
Can I share my screen?
Yes, you can. No.
Can you see my screen?
Yes.
Is it full screen?
No, it is not.
No, it's not full screen. Make it enlarge.
Now it is full screen.
Yeah, no, still not.
Huh?
No, no.
Now is it full screen?
Yes, I think, yeah.
Okay. So good evening, everyone, and welcome to this Master Trainer Orientation Virtual Program on Respectful Abortion Care, which is a joint initiative of FOXI and WHO. And I'll be talking on safe abortion, its updates and its technologies. So the overview of the session is what are the existing guidelines and how can we do the pre-abortion assessment, what are medical methods and the surgical methods of abortion. Now, people who are interested in the WHO global guidelines on safe abortion, they can go through these websites. These are available, it is available, everything is available on the website. And also there are certain national publications also on safe abortions, which is available. And the whole roadmap on safe abortion guidelines has been designed and has been adopted in our country, which has been given by WHO. Even Ministry of Health and Family Welfare National Guidelines on Safe Abortion has made a historic change in the MTP Act amendment in 2021. We have just heard what all the changes which has been done in 2021, and the law has changed on 25th of March 2021, and the rule has changed on 24th of September 2021. That is, it has been implemented from that day. So all guidelines have three key areas for the management of abortion safely, which include pre-abortion care, abortion care methods, and aftercare or the follow-up, which is the most integral part of this abortion service, where you can counsel these patients regarding contraception. Now, every woman has a right to take this decision for abortion, because that is her right, and she can take this abortion services, she can access to that abortion services, and that is because it comes under the essential services now. And we as a service providers have to provide these services to all our women who want this at any time and anywhere. And you cannot be judgmental, and you cannot impose or refuse the services, because this comes under essential services, and even the minor girls can demand for the abortion. Only at precaution where you have to take here is that, as it comes under POXO Act, so you must inform the concerned authorities, at least the closest police station where SHO should be informed regarding this procedure. Before going for abortion services for the minors, you must inform police for that. So that is what I want to say. So if the woman chooses to have an abortion, she should be allowed from the available methods which are available, that are appropriate for her, which are based on the duration of her pregnancy and her medical conditions. So what are the pre-abortion assessment and counseling? The component of pre-abortion assessment for women seeking first trimester abortion mainly include detailed history taking, general physical and pelvic examination, laboratory and other investigations, then the decision making regarding the abortion procedures, and the counseling, which is an integral part of it. Now, we all know that prior going for abortion services, we must determine the gestational age, which can be determined by LMP and physical examination. Many a times, people, they forget that, or they just, when the patient comes to us, she says that she is pregnant and immediately we go for the abortion services. That is not good. We must assess the gestational age prior doing the abortion, prior giving the abortion services. And it can be done by this, where the pregnancy dating should be done by physical examination, especially by the bimanual pelvic examination or the abdominal examination. We all know about that. I don't need to explain all this. Or after 4 weeks, the gestational, the uterus increases in size approximately 1 centimeter per week. Then at 12 weeks, it rises up to the pelvis. At 16 weeks, it is midway between umbilicus and the pubis and symphysis pubis. At 20 weeks, it is just the level of below the umbilicus. And after 20 weeks of gestation, fundal height should be measured in centimeters, which mainly approximate to the weeks of gestation. Now, why this is important? This is mainly important because you have to correspond. I mean, sometimes what happens, the size of the uterus is not corresponding with the period of gestation. Sometimes it is smaller. So that thing you have to see. Maybe if the size is smaller than the period of gestation, then maybe the patient is not, the woman is not pregnant. She had just a chemical pregnancy, or it may be inaccurate menstrual dating, or there may be some abnormal pregnancy like ectopic pregnancy, which should always be kept in mind in these early trimester abortions. And sometimes there may be spontaneous or missed abortion. And sometimes what happens, the uterus size is bigger than that of period of gestation. Again, it can be inaccurate date or wrong dates, or maybe multiple pregnancy, or maybe there may be some uterine, intrauterine space occupying lesion like fibroid with pregnancy can be there, or maybe molar pregnancy. So that should be and mute yourself. Now, regarding the pre-abortion investigations. So the latest recommendation is that routine lab test is not a prerequisite for abortion services. Once the patient comes to you for early abortion, you don't need to do all routine tests. That is what is the latest recommendation. Even ultrasound is not necessary unless you are diagnosing something abnormal, like ectopic pregnancy or missed abortion. So this is mainly done because all patients should be given the facility for safe abortion. That is why now the routine test is not included in that. And the test can be performed like if pregnancy is unconfirmed, then you can go for pregnancy test. If she is anemic, then you can go for hemoglobin test. If she's Rh negative, then maybe you will be needing to give NTD. So Rh testing can be done. Then HIV testing, STI should be screening can be done, or other laboratory tests if indicated, if she had some medical history. So KFT or LFT test can be done if required. But no patient should be denied for abortion services. Now, what is pre-abortion counseling? So once the patient has decided to go for abortion services, you should ask about what are the thoughts about terminating the pregnancy and what is the reason for terminating the pregnancy. But again, you should not be judgmental. You should never force on her or should ask her why you are going for that. You must listen to her, why she wants to go for this, and you should accept her decision. And finally, when you have decided to go for the abortion services, then you must inform her that early abortion is safe. What is the importance of trained providers performing the procedure for safety? Then available methods of abortion. Then what are the risks and warning signs associated with abortion methods? Then again, you must counsel her and tell her that without contraception, she can get pregnant as soon as 14 days after an abortion. So again, it is a wonderful opportunity where you can counsel her regarding contraception. Then you must also tell her regarding the resumption of her normal activities, including sexual intercourse, and any other problem if she has, that can be taken care here. Then another integral part is the documentation, which is very, very important in any abortion services. Informed consent should be taken, and decision to accept post-abortion contraception can also be taken. But if she is not willing for contraception, but that should not be the criteria not to give her abortion services. Like previously, many a times people have refused doing abortion service, giving abortion services just because she is not willing for a sterilization or she is not willing for contraception. So that should not be done. If she doesn't want, then you must respect her decision and you should give at least abortion services to them. So the method of first trimester abortion include this medical method of abortion, that is MMA, and the surgical method, that is MVA, that is manual vacuum aspiration, and EVA, that is electronic vacuum aspiration. So for medical abortions, global recommendation below 12 weeks is with mifepristone and mesoprestol, or mesoprestol alone, or vacuum aspiration. Whereas more than 12 weeks, global recommendation is mifepristone and mesoprestol only, and dilatation and evacuation. And you should never recommend dilatation and curettage. That is not recommended. But there is a little difference in India. Government of India recommendation for medical abortion, medical methods of abortion in India is only up to 9 weeks. So up to 7 weeks, that is 49 days, it is with mifepristone 200 milligram oral. Then after 48 hours, mesoprestol 400 micrograms sublingual, buccal, vaginal or oral, that can be given. Then for between 7 to 9 weeks, that is between 49 to 63 days, mifepristone 200 milligram orally. And then after 48 hours, mesoprestol 800 micrograms sublingual, buccal or vaginal. Mifepristone is an antiprogesterone, inhibits action of progesterone. It interferes with the continuation of pregnancy. We are not going in detail of that. And the mesoprestol causes cervical softening, uterine contractions, and expulsion of the product of conception. Now, what are the protocol for mifepristone and mesoprestol? On day 1, Mifepristone is given 200 milligram oral, and if she is Rh negative, then anti-D should be given with 50 microgram. On day 3, Mesoprestol administration, if the period of gestation is 7 weeks, then 400 microgram Mesoprestol, that is 2 tablets of 200 microgram each, sublingual, buccal, vaginal, or oral. And between 7 to 9 weeks, 800 microgram sublingual, buccal, vaginal. If she has an additional problem, like if she has pain, then ibuprofen can be given. If she has vomiting, then antiemetics, and again a wonderful opportunity for counseling her for contraception. Then she should be called for follow-up after 15 days, where again you can confirm and ensure completion of procedure, and again can offer contraception if it has not been done before. Now these are the routes of administration of Mesoprestol, that is oral, buccal, sublingual, and vaginal. And vaginal is the most acceptable because it has the lowest side effects, but the fastest onset of action and highest plasma concentration level is with sublingual. But again, it is associated with a lot of side effects like increased fever, chills, diarrhea, nausea, vomiting as compared to vaginal route. And buccal, again, same problem. Oral, normally it is recommended when pregnancy, early pregnancy, that is 7 weeks, that is 49 days. Oral tablets can be given, but again, it is associated with side effects like diarrhea, vomiting, nausea, and fever and chills. So this picture depicts the buccal administration and the sublingual application administration of Mesoprestol. This is WHO regimen regarding the dose of medical abortion. That is combination regime where Mefi and Mesoprestol is used. 200 milligram orally or 800 microgram buccal per vaginal or sublingual. And our alternate regime is this Mesoprestol, which in India we are not using. It is in few countries they are using, but in India we are not using this alternate regime, that is single dose of Mesoprestol, where 800 microgram is given buccally per vaginal or sublingual. Then patient should be told that vaginal bleeding can occur at least for 2 weeks, which is normal. And sometimes the bleeding can continue for 45 days in rare cases. But if it continues more than that, then she should be looked for, ultrasound should be done in that cases. Now, what are the provision of MMA services? Services should be available at the primary care level with referral systems in the place for all required higher level care. Then additional service may need to be provided to individuals seeking medical abortion, like counseling and testing for STDs, HIVs, abuse support services, psychological or social services, other specialist health or medical services. Then if she has anemia, then she should be provided with iron tablets. If she has pain, then that medication should be done. And she should also be given emotional support, which is now what we are seeing, that we have started with unsafe abortion to safe abortion, and now respectful abortion care. So that way we have changed our attitude towards our patients who are seeking abortion services. Now regarding the follow-up care, the recommendation is only the routine follow-up visit is only for those cases where medical abortion is being done with Mesoprestol alone, because there you have to assess the success of abortion. Otherwise, routine follow-up is not required, especially in the uncomplicated medical abortion using Mefi or Mesoprestol. You can call her for follow-up just if you want to counsel her regarding contraception, or if she has some other medical concern, or if she has any problem. In that cases, she can be called after 14 days. And what are you going to do in follow-up care? You must assess the woman's recovery, ask for any sign or symptoms of ongoing pregnancy, review any available medical record and referral documents, ask about symptoms, experience. If she has complaints, then focus physical examination for that particular complaint. Then also should have a fertility goal and need for contraceptive service if not provided earlier. Now, medical method of abortion is on one, that is first visit when patient comes. Once you have done pelvic examination, confirm that is the rate of pregnancy, then Mesoprestol of 200 milligram orally should be given. If she is Rh negative, the antidiuretic should be given. Then you should tell about that she should return back on day 3, and with that you must give her the contact address and phone number of the facility, so that if any problem she has in emergency, she can contact. And again, record her experience of any side effects on her MMA card. And it has been seen that after giving Mesoprestol, of men may expel completely, but her schedule for Mesoprestol should not be stopped. She should come on day 3 to take her next dose. So on day 3, you should give Mesoprestol 400 microgram, sublingual, buccal, vaginal or oral. Observe for 4 hours. If she has pain, then analgesics can be given. Again, a good opportunity for contraception. Advise she can adopt barrier methods or hormonal methods like oral or injectables. Then you must tell her that there may be bleeding for 8 to 13 days. Then she can take machinery, but she has bleeding and pain in abdomen or fever, then she must report. And also if there is no bleeding after 24 hours, so in that case, you have maybe consider the additional dose of Mesoprestol. Again, about within 4 to 6 hours after Mesoprestol administration. Now, that is the follow-up day. Pelvic examination should be done to ensure the completion of the abortion. And again, the contraception option like hormonal method, IUCDs, and if she is willing for sterilization, then maybe ligation can be done after her 1 menstrual cycle. Then she must be told that about that she may have that her fertility will return immediately. If within 6 weeks, if she doesn't have her periods, then she should report back. Ultrasound is needed only if the examination does not confirm the completion of procedure. What are the side effects? Again, pain, nausea, vomiting, diarrhea, and infection. Pain again, maybe because she may be stressful, so maybe that can be a reason. So you should be a person. If she has pain with that, you can give analgesics. But in spite of that, if the pain is persistent, then you must evaluate that case. Maybe there is some abnormal pregnancy like ectopic, infection, or incomplete abortion. So that should be looked for. Finally, for nausea and vomiting, usually it is self-limiting, or you can give antiemetics, or you can give reassurance. For diarrhea, again, it is self-limiting. You can give reassurance. For infection, you must confirm by pelvic examination, and you may have to start the antibiotics. Now, what happens when there is failure or incomplete result of MMA? So if there is a failure of medical method of abortion, you can offer vacuum aspiration, or you can repeat the dose again. And in the case where there is incomplete result of MMA, then you must observe unless heavy bleeding, unless there is heavy bleeding. If bleeding resolves by its own, then it may be a complete abortion, so you need not do anything else. Or you can repeat Mesoprestol in this patient, or you can also offer surgical method of evacuation. But if the bleeding is heavy in that cases, now if the bleeding is more than her menstrual cycle, and she is soaking almost 2 to 3 pads in 1 hour for 2 hours consecutively, then you must see. And if the bleeding is over time, then routine care, that is, you keep watch on her vitals, see for the bleed PV, and if it stops, then she can go home. But if bleeding continues, then again you can watch for her vital signs and PV examination should be done. See for any product of conception in the cervical canal, and you can also do the digital evacuation in that case. Now, if the woman becomes stable and bleeding reduces, then again observe and monitor, and if bleeding stops, then she can go back home. But if bleeding continues after that also, then you must go for ultrasound. And in ultrasound, if there is minimal decidual bits, again you can wait and watch. But if there is product of conception and decidual bits and the woman is stable, then you can give her Mesoprestol. If she's not stable, then you have to immediately go for vacuum aspiration. And if the pregnancy is continuing, in that case also you have to go for vacuum aspiration. This is the important part of MMA services, that is recording and reporting for the case. Since MMA comes under the purview of MTP Act, the documentation is similar as we do for the vacuum aspiration procedure, and it is always mandatory to fill all forms. That is, all 4 forms should be filled. That is Form C, which is a consent form, Form 1, which is RMP opinion form, Form 2, which is monthly reporting form, which has to be sent to district authorities, and Form 3 is the admission register for case record. And these should be confidential, should not be shown to anybody unless any authorities come and they ask for that. Now, what are the surgical methods of abortion? That is MVA and EVA. And vacuum aspiration is the recommended technique of surgical abortion of pregnancies up to 12 weeks. WHO recommends manual vacuum aspiration as the safest method, and the procedure should not be routinely completed by sharp curettage. Now, this is MVA syringe. I think all of you must be knowing about this, a very simple syringe, and I think each and every gynecologist should know how to do MVA, because that is a very simple way of doing vacuum aspiration, and it is a handheld aspirator used to generate vacuum. You don't need any electricity for this. It can be done anywhere, anytime, in any settings. Here the aspirator is attached to cannula on 4 to 12 millimeter in diameter, and these cannula can be used in multiple settings, including those without electricity. Then IPAS is the company which is, with whom this MVA syringes are there. And with this, they have a cannula, and these cannula size correspond with the weeks of gestation. Like 8 millimeter cannula will be for 8 weeks of gestation, 10 weeks, 10 millimeter will be for 10 weeks. So this should be known. Another vacuum aspiration method is this electric vacuum aspiration, where we all have this, and it is an electric pump used to generate vacuum. It can accommodate cannula of manual vacuum aspiration with correct size and tubing. But prior doing vacuum aspiration, you must do the cervical priming, which can be done with oral mifepristone, that is 200 milligram, 24 to 48 hours in advance, or Mesoprestol 400 microgram administered sublingually 2 to 3 hours prior to the procedure, or Mesoprestol 400 microgram administered vaginally 3 hours prior to the procedure, or Laminaria 10 placed intracervically 6 to 24 hours prior to the procedure. Initially, we were doing with Laminaria 10. Now, there are Dilapen which has come, which is recently it has been launched, and that is giving very good result if you want a slow dilatation of the internal os. Then pain management plan for vacuum aspiration procedure. This is again an important component to give a quality abortion care. You must reduce pain and anxiety and make women comfortable. And the two components of pain management is non-pharmacological and the pharmacological management. Now, non-pharmacological is providing psychological support, explaining each step to the woman in advance, making her comfortable, performing the procedure gently and smoothly, and encouraging the woman to relax and breathe deeply. Whereas pharmacological pain management plan include, if she has anxiety, then diazepam can be given, or general anesthesia, where diazepam 10 milligram orally, 1 hour prior to the procedure, or 2 to 5 milligram IV, 20 minutes prior to the procedure. And the duration of effect is around 4 to 6 hours. Again, side effects are disorientation or dizziness. For cervical dilatation, You can give local anesthesia with lignocaine, that is 10 ml 1% lignocaine, where the duration lasts for about 60 to 90 minutes. And analgesics like ibuprofen can be given with a dose of 400 to 800 milligram 1 hour prior to the procedure. And the duration of effect is around 4 to 6 hours. Again, the side effects are dizziness, seizures, and the gastritis. Now, for uterine clamping, again, analgesics can be given with a dose of 400 to 800 milligram at least 1 hour prior to the procedure. Duration of effect is 4 to 6 hours. Again, side effects is gastritis. So what are the steps of MVA? So for MVA, I think you all must have seen the MVA syringe. It has first we have to prepare the instrument, and for that, there is a valve in the front of the MVA syringe. You have to close that valve button, and then you have to pull the plunger out to create a vacuum and lock it. After that, you have to prepare the woman, ensure pain control medication has been given at the appropriate time, ask patient to pass urine and empty her bladder, and under aseptic precaution and in the proper lithotomy position, administer paracervical block. Dilatation has already been done by the priming of the cervix, and then you insert the cannula. After inserting, you should withdraw the cannula 1 to 2 centimeters away from the fundus inside the uterine cavity, and then rotate the cannula to 10 to 2 o'clock position with smooth, gentle motion. And then release the vacuum button on the aspirator so that all products of conception will be sucked inside the syringe. And how will you know that the uterus is empty? When you will see red or pink foam without the tissue passing inside the cannula. There is a gritty sensation over the surface of the uterus, or when the cervix is gripping over the cannula, or when the uterus starts contracting around the cannula and there is increased uterine cramping. These are the signs when you feel that the uterus is empty. And once you are ensured that the uterus is empty, then you must take out the cannula and take out and open the syringe and put the product of conception in the bowl and inspect the tissue, because that is very important. Many a times, if it is an ectopic pregnancy, nothing will come. So you should be suspicious in those cases, and that is very important to inspect the tissue. And then you can take a concurrent procedure along with this. Like if she is willing for sterilization, then ligation can be done accordingly. Or if you want to put IUCD, that can be done. And finally, you should clean the instrument for the later use. What are the post-procedure care? Monitor her for any complication and provide management as needed. She may leave the facility when she is stable and meet the criteria for discharge. Ensure that the woman has all necessary information and medication prior to leaving the facility. Finally, document all outcome of the treatment, including any adverse event, in the facility register, and even that should be documented in the client's record card. Aftercare, again, management of abortion complications like incomplete abortion, infection, bleeding, or ongoing pregnancy. Again, good opportunity to give contraceptive counseling at this time. Then you must also assess any other sexual or reproductive health need that may require additional care. Now, follow-up, normally the new recommendation which has come is only for those who are using Mesoprestol regime alone. Otherwise, there is no need for follow-up. But normally what we are doing at 14 days, we are calling patient in the case where there is some, if she has some problem, or if you want to counsel her regarding contraception. So in summary, India has made historic progress in improving access to safe abortion. Not much, although there is not much change in the technological update in the last decades, but you must ensure safety and quality, especially in the context of amended law, which we have just listened in the previous lecture. And we have started from the unsafe abortion to the safe abortion, and now we should need to focus on the respectful abortion services. Every client, be it a public or private, should give an opportunity. We must inform, educate, and we must equip with proper information regarding the contraception and also regarding the different methods of abortion. So thank you. I would like to remind you that you have already done the registration and pre-test, and after finishing this full module, you will be doing the post-test, and you have to fill the feedback form. Then only the certificate of participation will be awarded to you. So in India, abortion is legal. Let us make it safe and respectful. Samarth Bharat, that is, sustain, accelerate, mainstream access to reproductive health through health system. Samarth Bharat, that is Sampoorn Bharat. Thank you for patient hearing. If anybody has questions, can put it in the chat.
Now we'll move for module 3, right?
No, first, Dr. Kavita, if there are questions in the chat box, we will take that, then we'll go for the third module. Okay.
I don't think much
There
question.
Are many
One question.
How to get the pre-test and post-test link. See, pre-test is when you are registering. If you are registering, you will have to fill the form where the pre-test questionnaire will come, that you have to fill, and then only you will be registered for this module. So once you will do that, then you can join this meeting, and once you will finish this meeting, there will be an icon coming after you press the button, leave the button, and that icon will say either continue or leave. So you have to press continue, and then the post test will come. That also you have to fill, and then you will be given the certificate of participation. 7 weeks onward, not given oral. 7 weeks upward, not given. Madam, yeah. 7, normally, patients start having giddiness, nausea, vomiting. So that is why better to go for vaginal test.
Yes. So now I will start the third one.
Rekha madam, WHO manual will be after this session.
No, there is one more question, Dr. Rekha madam, there is one more question. How can examination confirm about complete expulsion of product? Why shouldn't we confirm by ultrasound? No, it's not that. It is, we are emphasizing that we must do give the abortion services to all patients, and if you have any doubt that abortion is not complete, like which doesn't have bleeding, if everything is okay, if the size of the uterus is normal, then you don't need to go for ultrasound. If she doesn't have giddiness, nausea, vomiting, all those things, so in that case, she need not go for ultrasound. Unless if you are in doubt, then you can very well send her for ultrasound. Ideally, ultrasound
Actually, it is to reduce the load of ultrasound.
So no. It is not to reduce the load. It is to give the safe abortion services to each and every patient.
That is why I'm telling you.
But in routine days, in day-to-day practice, we get ultrasonography done.
No, what I mean, you did not understand what I was saying. I was saying something else. I was saying that post-abortion, since it is the WHO recommendation to reduce the number of ultrasounds, they have said that by a pelvic examination, and if you are sure that it is not bleeding, then you should avoid ultrasound. Otherwise, you can go.
If the patient has any complaint of bleeding or pain or something else, then ultrasonography should be done. If not, the patient is fine regarding everything, then no need of ultrasonography.
The question was, why shouldn't we go? Why shouldn't we go? We can do it to confirm. The shouldn't word is because of the load.
What was happening now, I think everybody must have experienced now that we don't get any septic abortions now. Very less septic abortions cases are coming, and that is the reason why people are saying that each and every patient should have access for abortion services. So if you can give that without doing any ultrasound or without doing any investigation, that is best for the early trimester, in the first trimester. This is all we are talking about, the first trimester.
Now let us move on to the module 3. So shall I start, Kavita?
Yes, yeah. Most welcome, yeah.
So safe abortion values, evidence, rights, Respect. Respectful abortion care. It is a joint FOGSI and WHO initiative. I will just stop my video. This module aims to define respectful abortion care WHO standards, highlights how norms and stigma affect the services, provide WHO saver resources for respectful abortion care. The main thing is that the word respectful has been added and the stigma attached to abortion has been removed. The momentum has been created, law has changed, dissemination needs association, and OBGY providers support. FOGSI, the largest provider base for abortion care, since FOGSI is the largest provider base for abortion care, online training is possible due to COVID. Respectful abortion care can reach to all the providers. The medical methods of abortion uptake has increased. Early, safe, ensure no PCP-NDT conflation. Since there are more and more medical methods of abortion becoming more popular and it is safer, so it should be provided to more and more takers and should not be it should not be put off with anybody. Patient safety, respect and quality matters more than ever, and we all have a role to play. What is respectful abortion care? Adopted from respectful maternity care and recommended by WHO, respectful abortion care refers to care that maintains safety, dignity, confidentiality, and ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. So what does it mean? There should be safety, dignity, and confidentiality, freedom from harm and mistreatment, and informed choices given, and support during and also after the types of abortion. What is respectful abortion care? In the simpler terms, respectful care means you as a provider treat and are treated with dignity, empathy, and as a patient are treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history, pregnancies, miscarriages, or abortions. So respectful means that you as a provider, you are giving and the patient is taking. Both of you should be treated with dignity, empathy, and compassion, regardless of race, ethnicity, gender. Like if a poor person comes, still you have to talk in the same way as a very rich person comes. And if anybody from any race comes to you, you have to talk in a similar manner and very respectfully. If you ever feel that something isn't right, please speak up. As health professional, it is our duty to listen and to support. So what is the main thing? Communication is the key. Communication between the provider and the patient. What are the norms and stigma? We wonder what are the norms and what are the stigmas associated with abortion. Stigma and norms perpetuate disrespect and abuse. So some things are shown in red, some in blue, and some in green. So category of disrespect has been categorized as the red ones are the biggest abuse, physical abuse like slapping, intimidating physically, verbal abuse, non-consented care, shouting or screaming at the patient, sexual abuse, abuse of power, and taking advantage. Like if somebody is a male is abusing and forcing somebody to have an abortion or something like that, or speaking in a bad language, that is very bad. The fourth one is stigma and discrimination. This will be shown in the saver videos. What are the discriminations and what are the stigmas? Then fifth is failure to meet the professional standards of care. Sixth is poor rapport between the woman and the providers. And seventh one is health system conditions and constraints. Like many times we have seen somebody might just slap somebody if she is asking for abortion, or not speak in a respectful manner, give some verbal abuse as if she has done something wrong, or sexually abusing, taking advantage of her being female or with less of power, and discriminating between people, and failure to meet the professional standards of care, poor rapport between women and providers, and health system conditions and constraints. These can lead to disrespect and abuse. What are the rights of every woman? It is freedom from harm and ill treatment. There should be freedom from harm and ill treatment when she has come to seek abortion. Right to information, protection under laws, informed consent and refusal, and respect for choices and preferences, dignity and quality of care. Right to timely health care and to highest attainable health level of health, liberty, autonomy, self-determination, and freedom from coercion. So we have to keep in mind the rights of every woman, that she should be free from any type of ill treatment or harm. She should have the right of information and protection under all the laws of MTP and POCSO, and informed consent and refusal, and respect for choices, her choices and preferences, her dignity and the quality of care. Right to timely health care and to highest attainable level of health, liberty, autonomy, self-determination, and freedom from coercion. Domains of respectable abortion care. There are 12 domains of respectful abortion care. So, being free from harm and mistreatment, maintaining privacy and confidentiality, preserving the woman's dignity, respecting the woman's choices, engaging with effective communication, soft skills, softly speaking to her, providing information and seeking informed consent, ensuring continuous access to support and enhancing quality of physical environment and resources, providing equitable abortion care, availability of competent and motivated providers, and provision of contraception, advice and commodity security, and continuity of care and counseling. So we should always, while providing the care, abortion care, should always be in contact with the patient. The patient should have the phone number, or should have we should have their phone number to just contact and see whether everything is going fine with her or not. Time to strengthen the implementation. So again, this is a repetition. Up to 20 weeks, one RMP is authorized. Up to 20 to 24 weeks, between 20 to 24 weeks, 2 registered medical practitioners, and beyond 24 weeks, a medical board. The important changes for provider opinion. Every patient is an opportunity for respect, and as providers, onus is on us to educate and also to reduce the sex selective abortion. It is we who have to see whether it is a sex selective abortion or not, and how to prevent it. One provider is more responsibility, counseling, contraception, referral, and compassionate care. If you are doing up to 20 weeks, you are one provider, you have more responsibility, and better counseling is needed. Contraception services should be given, referral and compassionate care should be taken care of. Now, expanse of eligibility. Now how the eligibility has expanded, especially young people, survivors, unmarried, everyone needs unbiased care, and we need to overcome our own biases. Like earlier, when unmarried people came to abortion care services, then they were rebuked, or they were laughed at. This should be done away with. Up to 20 weeks of of gestation, all women are entitled. Anybody, even an unmarried person, have to be spoken in the same way as a married person, because it is her life, it is her choice to have sex or have abortion. Special categories which come between 20 and 24 weeks are rape and less than 18 years. A girl of less than 18 years, or a rape victim, if she comes after 20 weeks and between 20 to 24 weeks, you have to do it. And now comes the persons carrying fetuses with birth defects. There is no gestation limit, and a board is needed. So 3 things: up to 20 weeks, Do not deny from 20 to 24 weeks for rape victims and below 18 years and some others. And after 24 weeks, no gestation limit, but the board is needed for birth defects. It has to be done. Now, prioritizes confidentiality and safety. Respect begets respect. आप उनको respect दोगे तो वो आपको respect देंगे. As providers, we need to be mindful of any socio-cultural aspects. Name and other particulars of any woman seeking abortion should be confidential, except to a person authorized in any law for the time being in force. So, किसी मोहल्ले वाले को नहीं बता देना है कि वो फलाना आया था एबॉर्शन के लिए. कभी ऐसा नहीं करना है कि कोई तीसरा आदमी पूछ रहा हो कि अरे उस लड़की से मेरी शादी होने वाली है तो क्या उसने एबॉर्शन कराया है. नो, you cannot disclose. You have to be confidential about all these things. The ground of failure of contraceptive has been extended to woman and her partner. So it has to be done, and respect, quality, and dignity should be maintained at all times. Guide to avoiding stigmatizing language. So what are the types of stigmatizing language that you will know? Self-spaced games. These are the toolkits. There are some recap questions. Yeah.
Madam, there was a video, madam, actually. Those are videos.
Shall I play the video?
Yes, you have to play the video.
Yeah, play the video. Play the video.
Okay.
Go back on.
Yes,
Other slide.
I can't find that video. Can you play it for me?
Yes, ma'am. Stop sharing the screen, ma'am. I'll do that.
Stop sharing.
Okay.
You have to put this HTTP, no? That link you have to press.
Should I stop sharing? Then you will share the video?
Yes, ma'am.
Okay.
How to Talk About Abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term "keep" implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 Ps provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
So your module is complete, Rekha madam?
Yes,
Madam,
I
there is
think
another video to play, ma'am.
another video. There is another video.
Very good.
Yeah.
Another video. Okay.
There is another video, I think.
Okay.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Seva has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Seva is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
Okay, now you start, Rekha madam. You have finished your module? Hello? Rekha madam?
Yes.
Yes. So now,
I was muted, that is why.
okay. So it's finished now. Now another session will be taken by Dr. Roma Yadav.
Yes.
Okay.
Madam, there are still some more PPTs, madam.
Yeah, Dr. Rekha madam, there are few more PPTs after this. So you have to complete that.
Let me do it then.
Yeah, you just unshare. Shriman, please unshare.
Madam, I'll continue, madam. I'll change the slides, madam.
Okay. You continue with the slides then.
Okay,
Madam,
then you continue with the slides. I will just read it out.
Yes, ma'am. Should I change the slide, madam?
Yes. Change. Start changing. From 1970, unsafe abortion, to 2000, safe abortion, and now 2020 is respectful abortion. There are some recap questions. Go to the first question. According to the WHO, restricting the access reduces the number of unsafe abortions. Is it true or is it false? Anybody can
write?
Write in the chat box.
Write down in chat box.
You can write in the chat box. According to the World Health Organization, restricting the access reduces the number of unsafe abortion. Is it true or is it false? Next slide.
False.
So it is false. So even if you restrict the access, it will be the same. 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Should you ask her to continue or should you not ask her to continue? Yes, it is no. So the next slide, please. So it is no. It is her own free will whether to abort or not. It is, you cannot ask her to continue the pregnancy. Next slide, please. So up to 20 weeks, one provider. From 20 to 24 weeks, two provider, and after 24 weeks, the medical board. So now I think it is complete. Shriman, is it complete now?
Yes.
Okay.
Okay, thank you, madam. So now session 3B by Dr. Roma Yadadi. Start sharing, Romadi.
Dr. Archana, mute yourself.
Hello. After we have learned so many sessions on safe abortion and respectful abortion care, and now there comes the role of contraception after abortion, and for this, counseling is an important part for abortion.
I'll request Mithu Kumar to please mute yourself. Yes, Dr.
So after the access to the respectful abortion care, there comes the role of counseling for contraception. For this, we have a module on pre and post family planning counseling, leveraging technology for referrals and online consultations. Especially in case of COVID eras, the online consultations are important. Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. That's why the role of counseling is very much important. Pre and post-abortion care, it is an integral part of comprehensive abortion services. Pre and post-abortion counseling is also important for the procedure. The provider must tell about the procedure, about the details of the procedure to the patient. Women may need help in decision making, and this counseling, wherever needed, the spouse should also be counseled. If it is felt that only the women we are not able to counsel properly, then the husband or spouse should be counseled.
Click on the slide.
Yeah.
Click on the slide.
Yes.
Slide के ऊपर click करो. Slide के ऊपर. Yes.
Pre-procedure counseling. There are this module consists of pre-procedure and post-procedure. This pre-procedure counseling, it has critical role. It helps women to decide about termination of pregnancy. If you counsel pre-procedure, it helps women to choose the method of termination, and it ensures delivery of complete information about the procedure. It also helps women to adopt a contraceptive method. So before starting the procedure, we must counsel the women. The procedure are for of pre-procedure counseling. It ensures the women should be ensured privacy and confidentiality. It is a very important part of respectful abortion care. And we should be non-judgmental and be sensitive to the patient. Where there must be a rapport should be established between the provider and the patient. And we should use simple language and allow the woman to clarify her doubts. We should give time to clear her doubts. And if she has made up her mind for termination of her pregnancy, we should assess her for this procedure, whether she is fit for this procedure or not. Relevance of peri-abortion family planning counseling. This is help in quick return of infertility should be ensured. This is the opportune time for contraceptive acceptance. We should counsel about the contraception. And with minimum 6 months gap before next pregnancy. And health benefits and better future pregnancy outcome should be explained in a broad way. 90% of abortion-related maternal mortality can be prevented by ensuring contraception, because the repeated pregnancy may lead to her unsafe abortion. Pre-abortion family planning counseling. When to start? We can counsel her in the very first visit, or consultation. Except in case of the patient is in a case of dilemma or in grief, then this consultation can be delayed. What is the points to be counseled? That is the importance of because the return of fertility comes within a week. We can help her to pick and choose the right contraceptive methods. The method spacing counseling should also be counseled, and high-risk behavior whenever applicable. If the woman is not willing for any contraceptive method, do not refuse MTP. We will wait for the second time of her visit. Assessing suitability for post-abortion contraception. The general guiding rules are whether the abortion process is complete, where there is no existing infection, there should be no injury to the genital organs, and the chances of fresh pregnancy should be ruled out. And this for the post-abortion contraception, all these are needed. Post-procedure counseling. After doing the abortion, it has a critical role. It ensures we should ensure that woman has understood the precautions and care needed during post-abortion period. This is the best time where we can use the opportunity to counsel for contraception if in previously she has not accepted the methods of contraception. It reinforces the need for continuing the use of contraceptive method, whatever she has chosen. Post-procedure counseling procedure are continue, reassure, and repeat. That is, continue to ensure privacy and confidentiality. Reassure her in case of any problem. If there is any problem, if any problem arises, we must reassure her. And repeat the information about post-procedure care and danger signals. The post-abortion counseling are, if the woman has already adopted, then we should appreciate her. Immediate care like IUCD, Madroxy, Progesterone, Acetate injection, ongoing oral contraceptive pills, all should be continued, and for this the women should be encouraged. Follow-up protocol must be maintained, and continuity, that is reproductive intuition, should be there. And cards. If the woman is undecided about the family planning, then we should try to allay her anxiety. And importance of immediate adoption and choosing immediate adoption of contraceptive methods, and the different types of contraceptive methods should be offered to her. Extended period of adoption. If she is not willing at that very time, we should give further time to adopt the contraceptive methods. Couple counseling is also very important. Sometimes women is not ready for this. Then we can counsel the couple, and every woman should know about the emergency contraceptive pills. The post-abortion contraceptive methods. Post-abortion contraceptive methods are various barrier methods like condoms, and it can be used after the timing after abortion is in case of first trimester and second trimester. In first trimester, as soon as sexual activities resume, we should counsel about using the condoms. And in case of second trimester, as soon as the sexual activities resume. Additional information should be given to the women that there should be no hormonal side effects. It can be used without consulting a health provider. Condoms are easily available. It prevents not only against pregnancy, but also against STI and including HIV infection. Condoms enables men to take responsibility of contraception. The second method is the intrauterine contraceptive device like IUCD 380 and IUCD 375. Again, in case of first trimester and second trimester, in a first trimester, IUCD should be inserted immediately or up to 12 days after confirmation of a completed abortion using the surgical method. With MMA, inserted around the day 15 of the process, provided complete product of conception expulsion is confirmed and the risk of presence of infection or any other problem. So in case of second trimester abortion, the IUCD can be inserted immediately or up to 12 days after the procedure is completed and the contraindications are ruled out. We should give additional information to the women that this IUCD is highly effective. It provides long-term contraceptive. In case of IUCD 375, it gives protection again for 5 years, and in case of IUCD 380A, it gives protection up to 10 years. It can be provided by trained doctors like MBBS and above, A&M nurses after first trimester surgical abortion, and by trained doctors only after MMA, and by PP-IUCD trained doctors after second trimester abortions. It doesn't, this IUCD doesn't interfere with the sex. It can be removed immediately. And in case of IUCD, the patients, the women should be explained that there is no hormonal side effects. Now coming to the third contraceptive method, that is hormonal contraception. It contains the combined oral contraceptive pills. Again, the same thing after first trimester, immediately it can be used immediately or up to 7 days after abortion using surgical methods. With medical management of abortion, it can be started on day 3 with the dose of Mesoprestol or within day 15 of the process after confirmation of completed abortion. In case of second trimester abortion, it can be this COC can be used immediately or up to 7 days after abortion. This combined oral contraceptive pills, it regulates the menstrual cycle. Additional benefits are it regulates the menstrual cycle. It can be provided by all health workers after first screening by the trained provider. It doesn't interfere with sex. It offers protection against ectopic pregnancy, endometrial and ovarian carcinoma, and benign diseases such as fibrocystic and fibroadenomatosis. But it is not suitable for women who are breastfeeding babies less than 6 months old, and for this, the progesterone only pill is available as a contraceptives. This long-term, coming to the hormonal contraceptive, that was the oral, and the injectable one is Madroxy progesterone acetate injection. Again, after first trimester abortion, it can be given immediately or up to 7 days after abortion using surgical method. With medical management of abortion, it can be started on day 3 with the dose of Mesoprestol. And in case of second trimester abortion, this Madroxy progesterone acetate injection can be given immediately or up to 7 days after abortion. Again, it has additional benefit. This Madroxy progesterone acetate injection, it is highly effective. Confidentiality and privacy is maintained in this method of contraception. It can be provided by doctors, MBBS and above, AYUs, ANM, nurses, after screening by the doctors for the first injection. It doesn't interfere with sex. It has no effect on the quality and quantity of breast milk, so can be given freely to the lactating mother. It has no estrogenic side effects. It offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. That was the temporary method of sterilization, and now we are coming to the permanent method of contraception. For this, the female sterilization and male sterilization. Female sterilization can be performed after an abortion in the absence of any infection or severe blood loss. There should not be low hemoglobin or severe blood loss, or concurrently up to 7 days. Both mini lap and laparoscopic sterilization can be done. With medical management of abortion, it can be done only after the first menstrual cycle. Sorry. In case of second trimester abortion, mini lap sterilization can be performed concurrently or up to 7 days after an abortion in the absence of any infection or severe blood loss. Laparoscopic sterilization is not recommended in case of second trimester abortion. In both the cases of female sterilization, we should take care of infection and anemia. The additional benefit in this female sterilization is it is a permanent method of contraception. It is highly effective immediately. Again, it has no interference with sex, no effect on breastfeeding, no long-term side effects, and it offers protection against ovarian cancer. Coming to the male method of sterilization, that is vasectomy. It is performed on males independent of the timing and procedure of the abortion. This vasectomy is very effective. It is a permanent method of contraception. There is no interference with sex, no long-term health risk, and couple must use another method of contraception. So the various contraceptive methods with medical management of abortion are the combined oral contraceptive pills can be started from day 3, injection and centochromine also, and IUCD on day 15. And again, COC can be started after T15. Contraceptive methods with vacuum aspiration. COC can be given at any day. Injection, also injectable contraceptives can be given, and centrochromine can also be given. IUCD can be given, and tubal ligation can be done at any time, irrespective of the time of vacuum aspiration, except there is no infection. There should be no infection and no anemia. As far as service, teleconsultation and other technology. By leveraging technology, the service provision are teleconsultation, telecounseling, teleguidance, telereference, and telelinkage. This type of service we can provide. This has a great role in during the COVID period. We have used this method. The leveraging technology are techno-IEC, information and communication, information, education, and communication. The websites available: Hamdo, social media, Ask Tanu, YouTube, infographics, helpline, and patient education platform like WHO, MOHFW, and RCOG are available. This SWOT of teleconsultation. SWOT of teleconsultation is S for strength, W for weakness, opportunity, and threat. The strength of teleconsultation are: it is useful in COVID, that I've told, it is useful in COVID era, approachable throughout the process. There must be approachable throughout the process, and awareness, spread out questions and answers at ease. They can raise the questions and we can give the answers with our choice of time. Weakness are: there is no face-to-face weakness is face-to-face consultation and demonstration. We can also demonstrate on teleconsultation. Opportunities are privacy and comfort. It is cost saving and no visit. Visits are cut down. But the threat is there may be missed opportunity and also misdiagnosis. Applicability of components of CAC. That is assessment, confirm the diagnosis, and assess the contraceptive need. Counseling, video conference, Zoom, by using the video conference Zoom platform. Follow up by hybrid service, 1 visit, or medical method of abortions, 3 visits. We can provide both physically and online or by teleconsultation. We must realize the key message are realize the need of post-abortion family planning methods. It brings the couple on board and strive for 100% coverage. Capitalize on basket and applicability in post-abortion period. Technology as far as possible, scope for entry in CSA services. Concern is policy, malpractice, service cost, and access. Adolescent reproductive health needs both online and offline. This comes to the end of this session. And now we will proceed for the pre-test and post-test feedback and also.
We have to continue and we have to appear for the post-test. Then only we will get the certificate. Okay. Srimant, where is the continuation? There is option only leave. So where is the option for continuation? Hello?
Hello,
Srimant?
Dr. Kavita.
Hello, Kavita.
Yeah, once you will leave, no, you have to wait for 1 minute. The center, it will come continue or leave. So that continue, you have to press. Okay?
Also, first we have to leave.
Press the button, leave.
Srimant is saying something. Yeah.
Madam, I posted the link in the chat box also, madam. If you click on the link,
okay. Yeah. Thank you. Yeah, that's better. Okay, thank you.
So there is a link in the chat box. Anybody can click on the link and do the
Chat box.
post test.
Post test,
Thank
yes.
you. Yeah, thank you.
That is better, I think.
Yeah, that's better.
In the chat box.
Yeah, better.
You don't need to stay in the meeting, madam. You can leave the meeting and you can fill the post-session feedback.
Yeah. When you will leave, no? After that, in the center, it will come, continue or leave. So that you have to press.
Okay.
So let us, I think there's no questions in the chat box, no? So we will leave now. Any questions?
Yes. No. There's no question.
No, I think Dr. Archana has written something. Permanent methods are good. What do you want to speak something on that, Dr. Archana?
Only that we should implement all these informations in our day-to-day practice. That is the only thing I want to share with all of you, because in our busy schedule, we are not doing our 100% regarding family planning advices and implementation, because in our labor room also, we are not providing contraception to all the patients who are coming. That is only my query and request to all.
So we can all keep
And
on speaking on
one
this.
minute, madam. Ek bas main batana hai. Like people had confusion regarding ultrasound. So I just want to tell you ki it is given by WHO that if you have a facility for ultrasonography, you can go ahead and do and confirm the pregnancy. But
it is not necessary.
But the places where it is not available, just on the basis of ultrasound, you should not deny the abortion services to that lady. That is what the aim of saying. So those who have ultrasound facility at their own place, they can very well go and do it and can confirm the pregnancy or see for the incomplete or complete abortion.
Yeah,
So
even those who have the facility at the nearby facility, or those who can afford, they can go, but you should not deny abortion at any cost.
That is
just because of the ultrasound.
But we should counsel about the ectopic pregnancy, chances of ectopic pregnancy or any bleeding that may lead her.
Any suspicion will definitely guide you to take an ultrasound.
Counseling is a part and parcel of everything.
ऐसा नहीं होना चाहिए कि आपके पास फैसिलिटी है तो just because कि ये बोला नहीं गया इसलिए you are not doing that. It's not like that.
All of you,
have
please,
facility, you can use that facility.
Please go on the link and do the post test. Please go on the link and please do the
link. I'm not able to see the link.
I think you just leave the session and go for the continue.
In chat box also there is link. Romadi.
It is not coming.
Who is asking?
कविता लीव करने से लीव हो जा रहा है
क्या? लिंक नहीं हो रहा है?
तो लीव हो जा रहा है.
हाँ so you leave.
लीव करके ज्वाइन करो. नहीं लिंक खोलो ना तो लीव नहीं है.
You have to leave.
लीव किया तो लीव भी हो गया.
नहीं तुम चेंज करो अपना ईमेल एड्रेस. लिखो चेंज ईमेल. लिखो ना चेंज द ईमेल. आ रहा है ऑप्शन चेंज द ईमेल. मेरा वाला समर्पण हॉस्पिटल आ रहा है.
कहाँ लिखे चेंज द ईमेल?
No, immediately you are getting the post feedback form.
Yeah.
When you will click on the link,
तो डालिए ना पासवर्ड तो दिया हुआ था.
नहीं मैम आपके मेल का पासवर्ड चाहिए होगा. आपके याहू का पासवर्ड चाहिए होगा.